Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Good evening. Welcome to your Direct Connection. Tonight, the patient-in-chief returns to the White House. Even though doctors say he's not entirely out of the woods, President Trump, after 72 hours at Walter Reed, is set to continue his coronavirus care at the White House Medical Unit. Trump saluted his supporters who gathered outside the hospital with a controversial drive-by over the weekend. He has received several medications, including one normally used in the most serious cases. Joining us tonight to answer your questions about the virus and how we can all stay out of the hospital is Baltimore County Health Officer Gregory William Branch, himself the survivor of a COVID-19 infection. Dr. Branch, it is great to see you again. It's been a couple of months since you had this, but how are you feeling?
I'm doing excellent. And Jeff, I want to say to you, thank you for having me on the show today.
It is always a pleasure. Now, I'm sure we didn't get to talk before the broadcast, but I'm sure you're not going to want to second guess what the president's doctors were doing in terms of medications. But I do wonder if you have a comment about a tweet that the president sent this afternoon saying, in part, don't be afraid of COVID. Should people be afraid of COVID?
I would say that people should definitely be aware of COVID, and they should understand that COVID is here, it's real, and it's potentially deadly.
Well, this is a great chance. It's in the news. Everybody's thinking about it. Everybody has an opinion about the president's case, the spread of the disease in the White House. Let's just review some basics here. What are the guidelines that you're telling people so that they can stay safe in Baltimore County and elsewhere?
I always tell people to remember the 3 W's. That is, watch your distance, wear your face covering, and always wash your hands. So remember those 3 things, and I think you'll be fine.
That's exactly in line with what the Centers for Disease Control is saying. They also talk about sanitizing surfaces, and if you're going to cough, covering, cough into your sleeve, that sort of thing. Exactly.
It's always important to do that. And I also tell people to stay home if you're not feeling well. Always very, very important.
Now, what's happening in your neck of the woods? We know the statewide numbers have been stable at relatively low levels. We had a day last week where nobody died in Maryland of this disease for the first time in 6 months. Seem to be averaging a few deaths per day, unfortunately. The hospitals, maybe 80 people on an average day in intensive care, a few hundred in hospitals spread across the state. What are you seeing in Baltimore County?
So I can tell you for Baltimore County, we have approximately 18,409 people who have suffered from COVID. I can also tell you that we've had about 611 people who have died secondary to COVID. And right now, our positivity rate, meaning the percentage of people who are positive, is approximately 2.4. So the numbers are waxing and waning. They get a little better, a little worse, a little better, a little worse. But overall, compared to where we were in March and April, we're doing much better now.
Let me remind our viewers, if you have a question for Dr. Branch, you can give us a call. We'll have the number on the screen. You can also email a question to livequestions@mpt.org. You personally have an experience that's important for a lot of people to hear. So we know the president with this disease is going back to a White House where there presumably are some people who haven't caught it at this point. When you had this, I don't believe you were hospitalized. You were at home and you isolated yourself and nobody else got it, if I can recall. What's the trick if you don't have his house, on Pennsylvania Avenue that big, and you want to protect your family, what do you do?
Well, I would say that the best thing to actually do is, as soon as you think that you have some type of infection, so if you start getting any type of symptoms, and for me, that was a mild cough, I was losing my voice. When that started happening, I immediately quarantined myself from my family, stayed in my room, and then I immediately went the next morning and was tested. While I was waiting for my test results, I remained quarantined. And a couple of days later, my test came back positive. So at that particular time, I then went on isolation. And the difference between quarantine and isolation is just the fact that a person who is now in isolation knows that they are positive. And then anyone else in my family who lived with me, they had to obviously go in quarantine. It's very important that you do it as soon as possible. And I think because I did that so very quickly, that no one else in my family came down with COVID.
Let's take a phone call from Allegheny County. This is Lisa. Lisa, thanks for the call. Go ahead.
Hi, thanks for taking my call. With the opening of schools and churches and Sunday schools, et cetera, how do we balance the novovirus versus the coronavirus when the flu season kicks in?
Thank you very much, Doctor. How worried are you about the flu this year?
We're always worried about the flu because the flu itself also can be deadly to some people too. And at this particular time, what we know is the symptoms for flu are the same symptoms for the COVID virus. So what happens is that if you start to develop any type of symptoms, I would say call your doctor immediately and go get tested immediately. And because the only way that we can determine which one you actually have is really by getting a test.
Let's talk about flu shots for a second. What are you doing in Baltimore County? And I wonder if it's advantageous. I've heard of a couple places doing outdoor, possibly drive-by flu shots, so you don't have to go into a crowded space to get the shot.
So at this time, we're giving flu shots in the midst of a COVID pandemic. And so therefore, if you can remain outside in the fresh air, that's always going to be better than being inside. And yes, we in Baltimore County, the Department of Health will be giving out flu shots. And you can look at our website, baltimorecountymd.gov, and it will tell you exactly how you can do that. But flu shots are being given out at all of your local pharmacies, the grocery stores, urgent care centers, hospitals, and your doctor's office. So you can get a flu shot from anywhere at this particular time. And I do strongly recommend that everyone get the flu shots because you don't want to get the flu and the COVID simultaneously.
Wow. Doctor, you mentioned how you were successfully able to keep this from spreading within your household. Viewer wants to know by an email question, what about the situation where the president, who has it, wears some sort of mask, looks like an ordinary mask, and gets in a vehicle to either go for a drive or to transport back to the White House? The people in the car who looked like they were wearing N95s. Is there any way to make that safe or safer?
At this particular time, irrespective of what is going on, I would say that it is not a good thing to be riding in a car with somebody who is positive for COVID only with a cloth mask on, even if that person has an N95 on. You would definitely want to have the windows rolled down. You would definitely want to be in the car for the shortest amount of time. And so it concerns me that the president would have some of his workers in the car with him, windows rolled up, kind of just sauntily driving along. That is not a good thing for the other individuals who are in that car.
Let's take a phone call from Baltimore County. This is Nazi. Thank you for calling. Go ahead.
No, Nafi, N-A-F-I. Thank you so much
Oh, I see.
Yes, thank you so much for taking my call. I have a question. On the news, I see every afternoon it shows the COVID positivity. It's like, 2 point some, and this afternoon was 3.5 or 4. But this positivity is totally different than the positivity that the Bloomberg and Johns Hopkins records. That Johns Hopkins is 4 point some, close to 5. What's the difference?
Great question. So glad you asked.
So basically what you have to do, it depends on specifically how they're calculating their positivity. So the key is not looking at two different ones of how they calculate it. The key is to continue to compare it to itself. So what I would do for the positivities that comes out of Johns Hopkins is compare those positivities with each other. And then the ones that are coming out of the state, I would compare that only to the state. And then you can see if there's a significant difference or not. But the two different ones is just the fact that there are different scientists who are actually calculating those, and their calculations are slightly different.
Question about testing. A little bit of confusion even on our program. We had somebody recently indicate that they didn't need masks at the White House because they were doing constant testing and everybody was negative. But is it possible that before somebody would have a positive test, they could have the disease? They may not have symptoms, they may not have enough to trigger a positive test, but could they spread it at that point?
So one of the things you have to remember is that tests are not foolproof. So that you can take a test and it can be negative, but it can be an actual false negative. And you can also take a test and it can be positive and it could potentially be a false positive. They're not perfect. So what happens is you can actually be taking a test. It comes up negative, but the person in fact is positive. And then they are spreading the COVID disease. And that's what might have happened in the White House. So that's why it's always important to do the 3 W's, wear your face coverings, wash your hands all the time, and watch your distance. You need to continue
and that is a perfect place to leave it. Dr. Branch, I'm afraid we're out of time, sir. Thank you very much. And Direct Connection continues right after this.
Drop your phone and just be in the moment.
You guys ready?
Yeah!
It's a thrill to see images of a new world for the first time.
I want to look back and say, I learned something. That is where transformation happens.
I see people cry on this show, and I'm like, what y'all doing, man?
Out of the water came this giant thing.
That's incredible.
I feel it in my bones.
It's so totally amazing.
They hear that song and they're like, that's my story.
I have chills.
All of the joys, all of the sorrows.
This is where it comes from.
The rest is history.
Joining us for our Your Health segment this week is Dr. Aaron Rada, plastic surgeon at the University of Maryland Medical Center and the University of Maryland St. Joseph Medical Center, also an assistant professor of surgery at the University of Maryland School of Medicine. Doctor, thank you very much for joining us. October is Breast Cancer Awareness Month. You do reconstructive procedures after somebody has had a mastectomy. I'm curious how that world has changed or evolved over the last 5 or 10 years.
Well, thank you so much for having me. I'm happy to be here. I do breast cancer reconstruction after both mastectomy and partial mastectomy, or otherwise known as a lumpectomy. And there's quite a lot that has changed as surgical techniques have become more advanced, as the implants that we use to do breast reconstruction have become more advanced as well. We're able to offer women both more choices in terms of the type of reconstruction they get and the timing of that reconstruction.
Unfortunately, it's a disease that affects a lot of people, and I don't know how many wind up with surgery or what type of surgery, but what's the process after that in terms of the length of time before they might see you when they may initially be undergoing some sort of medical therapy as well?
Well, the great thing is that most women are able to at least start their breast reconstruction at the same time that they're getting their breast cancer surgery. So typically a woman will see a breast cancer surgeon who will meet with them and discuss their cancer, who will discuss different options for the cancer surgery itself, and then we'll refer them to see myself or another plastic surgeon. And I feel pretty lucky that I get to have this sort of silver lining conversation with women. And so before they ever get their cancer surgery, we usually have a plan for their reconstruction. We sort of go over all the options, and part of my job is really to educate women about what options there are. And we can often at least accomplish a significant portion of their reconstruction at the time of their mastectomy.
How often would you say it's a one-day thing?
Well, women who have a mastectomy can often get either a tissue expander or an implant placed at the time of mastectomy. Most frequently, it's not just a one-shot operation, but luckily the subsequent operations, sort of the little touch-ups, like I like to call them, are shorter operations. They're outpatient surgery, so not something that require that you stay in the hospital for. And they can be scheduled around a patient's life. It's not a cancer operation, so it can be scheduled when you have time off work or your kids are covered and that kind of thing.
Is it the sort of thing where it's never actually too late to do it? I mean, if somebody decides 6 months later, a year later?
Oh, absolutely. I tell women that all the time. The majority of women who are having breast cancer surgery and who see a plastic surgeon will elect to have some kind of breast reconstruction at the time of mastectomy, both in the United States and globally. But for women, occasionally I'll talk to a woman who's not interested in any type of breast cancer reconstruction. And I tell them, if at any point down the road you decide that you want reconstruction, it's never too late. You can always go and see a plastic surgeon and discuss options for reconstruction. And really, most options are still available to women, even if they choose to delay their reconstruction until later for whatever reason.
Obviously, this is a horrible diagnosis, a terrible time psychologically to go through for a woman and her family members. Psychologically, how does the reconstruction procedure fit into that?
It is a challenging time, and I'm frequently meeting patients, after they've gotten this diagnosis. And you're right, it's incredibly stressful for women and their families. And unfortunately, breast cancer is so common that most of us will know someone who gets breast cancer over the course of their life and will be at least somewhat affected by this disease. So not only do you have this diagnosis that you're contending with, but you also are having to process a lot of new information, both from your plastic surgeon, from your breast cancer surgeon, from whatever other members are involved in your care. So it's a challenging thing to just wrap your mind around, and you're forced to process a lot of information. It's really a lot at once. And I like to think of my role as helping people see sort of the light at the end of the tunnel, that, my goal is really to help women see past the cancer and focus on their goals for how they want to look, how they want to feel, and to restore that feeling of wholeness after dealing with breast cancer.
The implants, of course, historically have had some complications that people may associate with the materials involved. You indicated things are getting safer. Is that part of it?
Well, breast implants have had sort of a long history. The implants themselves have evolved over time from first generation implants to the implants that we have today. And that's specifically referring to silicone or gel breast implants. In the past, the early silicone implants that were made, the silicone itself was pretty liquidy. So if you cut into a silicone implant, the silicone would sort of dribble out. The breast implants actually have one right here. Not sure if you can see this, but the breast implants that we have now, this is a silicone breast implant. The silicone inside this is more highly cohesive or bonded together. So if you were to cut into the side of this implant and squeeze it, the silicone would kind of squeeze out and then go back in. It would say stuck together. So that's one advance that's been made as far as the implants themselves go. But silicone breast implants really have been extensively researched for safety profiles. And there have been many scientific studies that have looked for correlation between silicone implants and various diseases. And there hasn't been a significant association between silicone implants and autoimmune disease, although it's still an ongoing area of study.
Aside from the timing of having this procedure, are there other choices that women have to make in terms of the exact nature of the reconstruction that you're going to do?
I like to tell women that in general, there are two main flavors of breast reconstruction. The first being implant-based breast reconstruction that we've sort of talked about. And I do just want to go back and mention that one thing that has been in the news lately that is associated with certain types of implants is something called ALCL. And I don't know if you'd like to chat about that more, but that's something that women should discuss
not
with
heard
their...
of it.
I'm sorry?
I know I've not heard of it, so please go ahead.
Breast implant, there's a rare cancer that women can get after they have had a specific type of breast implant, we think. It's referred to as BIA-ALCL, and that's like a really long name that occurs after some breast implants are placed. It's actually not a breast cancer at all. It's a T-cell lymphoma. It stands for anaplastic large cell lymphoma, and it's actually a cancer of the immune system. It's very, very rare, but it's something that's been in the news recently, and there have been FDA hearings about it, and it's really an ongoing area of study. So we think that this is occurring in patients primarily who have what's called a textured implant, and that's where the shell or the surface of the implant is rough or textured. We don't think that it's as likely to be associated with smooth implants like the one that I just showed you where the surface of the implant is smooth. But that is something that's being studied actively. Just to follow up on the last question that we talked about. But like I was saying, in general, two main flavors of breast reconstruction. There's implant-based reconstruction and autologous reconstruction, which just means that you're taking tissue, skin, and fat from elsewhere in your own body, and that's being used to replace the breast tissue that's removed at the time of mastectomy. The other option that women have is if they're undergoing a lumpectomy or partial mastectomy where not all of the breast tissue is being removed, we can often assist with those patients as well, doing symmetry procedures to make sure that if you've had some breast tissue removed from just one side, that they look nice and symmetric after surgery.
And in situations where somebody is having a mastectomy, not because of a cancer diagnosis, but because of family history or genetic indications for that, is it possible there to do everything in one setting?
Typically, yes. The full spectrum of options are available to women who undergo those risk prevention mastectomies, what we call prophylactic mastectomies. So those are women who have a family history that puts them at high risk for developing cancer, but don't actually have any breast cancer at the time of surgery. So those women are candidates for implant reconstruction or autologous or your own tissue reconstruction. And often we can put in a breast implant immediately at the time of mastectomy.
And before we go, the importance of catching this condition early, doing the self-exams or medical exams, whatever it takes to catch it while it's most treatable.
Certainly, if any woman notices anything different or anything that has changed on self breast exam, I would encourage them to go see their physician, whether it's a breast surgeon, primary care physician, their GYN physician, to be examined. And then screening mammograms are quite important. Screening mammogram age, the age at which you will start mammograms depends on whether you're average risk or high risk for breast cancer. That largely depends on your family history. But you are certainly right that we have a much better chance of curing breast cancer the earlier it's caught. So it's kind of an intimidating process, particularly if you're doing it the first time, but well worth it.
Dr. Erin Rada with the University of Maryland Medical Center, University of Maryland St. Joseph Medical Center. Doctor, thank you very much.
Thank you so much.
And that is our program for this week. If you'd like to see Dr. Branch's interview again, visit YouTube and search Maryland Public Television. Remember to follow us on Twitter and Facebook at MPT News, and join us Friday for State Circle. For all of us at MPT, thanks for watching and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.